When implanting the biflex toric IOL, the surgeon should always make it rotate clockwise. Never counterclockwise, even if the steep axis alignment is passed. Surgeons should stop the lens rotation while the capsular bag is still filled with viscoelastic, when it has reached a position of 1 to 2 hours before the steep axis, which means 15 to 20 degrees. If, when removing the viscoelastic, this creates a clockwise rotation past the steep axis, then the surgeon should re-inflate the capsular bag and rotate the IOL clockwise nearly 180 degrees to properly realign the axis of the IOL with the steep axis. In no case should the IOL be rotated counterclockwise or without the necessary quantity of cohesive viscoelastic. A postoperative rotation inducing an angle on the steep axis up to 30 degrees will no longer offer any astigmatism correction, but will still present the appreciable vision improvement linked to the cataract correction. When alignment of the lens with the steep axis is respected during surgery, then the patient astigmatism is reduced by at least 80% with the biflex toric. Indeed, the lower the postoperative rotation is, the better the results are. And biflex toric offers an optimal rotational stability with a maximal postoperative rotation of 5 degrees.
Quand vous implantez une lentille torique, son pouvoir diminue.
When you implant a toric lens, its corrective power decreases the further away you go from the axis you define. This loss of corrective power can be expressed as a percentage within a variance of 30 degrees in relation to the axis you originally defined. If you implant the lens with a difference in angle of greater than 30 degrees in relation to the axis you originally defined, then the correction is no longer astigmatic but just spherical. So you have a margin of 30 degrees in which to work to reverse the astigmatism. Of course, the thicker the cylinder, the more you must ensure that a small deviation from the axis does not lead to significant over or under correction. When you implant the toric lens, you must position it exactly on the axis defined beforehand. If the toric lens is implanted with an offset of 10 degrees in relation to the appropriate axis, this causes a loss of corrective power of the lens of around 30%. If the lens is offset by 30 degrees, the loss of corrective power is 100%. In other words, you achieve zero astigmatic correction, and the result for the patient is the same as that achieved with an ordinary spherical lens. So you have a relatively comfortable 30-degree margin for maneuver.